Have you ever stared at an ECG readout and felt your own heart rate spike just looking at those chaotic, squiggly lines? Yeah, you're definitely not alone. For a lot of us, looking at a 12-lead ECG can feel like trying to decipher an ancient, totally foreign language. But in today's explainer, we're going to eliminate that anxiety entirely. We are taking a highly structured, totally stress-free road trip through what we like to call Heart City. And by the end of this journey, you're going to have a crystal clear roadmap to confidently navigate any ECG that comes your way.
So here's the core philosophy for this explainer. The easiest way to learn ECG interpretation is absolutely not to torture yourself trying to memorize hundreds of complex individual patterns. Seriously, skip the rote memorization. Instead, you just use the exact same order every single time. If you always ask the exact same questions in the exact same sequence, you will easily diagnose the vast majority of ECGs. It's really all about following a simple, repeatable process. All right, here's our itinerary for today's road trip. We'll kick things off with Welcome to Heart City, then check our speed and road conditions. After that, we'll look at cops, gates, and lanes, navigate the hills, valleys, and danger. Then we'll actually diagnose the disease and wrap the whole thing up with a 1-minute checklist. Okay, Section 1. Welcome to Heart City speed and road conditions. Step 1 of our blueprint is checking our speedometer. Are we going too fast, too slow, or just right? Think of the turtle as bradycardia, which is that sluggish heart rate of less than 60 beats per minute. On the flip side, the rabbit is our tachycardia, zooming along at over 100 beats per minute. And walking pace? Well, that's our normal, healthy rhythm, cruising comfortably right between 60 and 100 beats per minute. Pretty simple, right? Before you dive into the weeds and look at anything else, you just look at the overall rate and ask, are we crawling, walking, or running? Moving on to step 2, we're evaluating the actual conditions of the road we're driving on. Essentially, is the rhythm regular? You figure this out by looking at the R waves. You know, those big, sharp upward spikes on the paper. If there's an equal distance between those R waves, you're driving on a nice, smooth, regular road. You'll see this in normal sinus rhythm or even SVT. But if that distance is unequal, you've suddenly hit a bumpy, irregular road. This is a huge clue. It immediately points us toward conditions like atrial fibrillation or frequent ectopic beats. Section 2. Cops, gates, and lanes. Directing the traffic. So let's dive into step 3. We are looking for P waves. You basically need to look at the strip and ask, who is the boss here? The P wave acts a lot like the traffic cop of the heart, directing the flow. If every QRS complex has a P wave right before it, the cop is on duty and doing their job perfectly. That's your normal sinus rhythm. But if there are no P waves at all, the traffic cop is just missing in action, which signals a major detour, like atrial fibrillation. And what if you see a bunch of rapid sawtooth waves instead of normal P waves? Well, that's atrial flutter, which is a totally different kind of traffic jam. Now, step 4 brings us to the ventricle door, representing the PR interval. Here, we're checking to see if every single P wave is actually followed by a QRS complex. Picture the P wave as a car, driving up and knocking on the ventricle's gate. If that door opens every single time, you've got normal, healthy electrical conduction. But if that door is sometimes closed, say letting a car through on one beat but completely blocking it on the next, you're looking at a second-degree AV block. And if the door is completely always closed and absolutely no cars from the atria are getting through that gate, that is a complete heart block. Honestly, thinking of it this way is an incredibly visual trick to understand exactly what's happening electrically. Step 5 checks the width of our lanes, which means the QRS complex. Is it narrow or is it wide? A normal, narrow QRS is less than 120 milliseconds. That just means your electrical impulse is cruising down the correct, well-paved highway. But a wide QRS, 120 milliseconds or more, means you need to immediately start thinking about the ventricles. I really want you to remember this simple phrase, wide equals wrong way. The impulse just isn't using the normal pathway. This points straight to serious issues like ventricular tachycardia, a bundle branch block, or even a systemic issue like hyperkalemia. All right, Section 3, Hills, Valleys, and Danger, the topography. Navigating this specific topography is the part that can literally save a patient's life. For step 6, we're scanning the horizon for ST elevation or depression. If the ST segment looks like a mountain, that's ST elevation, your clinical alarm bells should be ringing at absolute maximum volume. That mountain points directly to a STEMI. It's a major, life-threatening heart attack that needs intervention right now. On the other hand, if the ST segment dips down into a valley, ST depression, we're looking at ischemia or a non-STEMI. Mountains and valleys, they both demand your immediate attention, but they're telling a completely different, highly urgent clinical story. Step 7 is all about reading the electric signs along the side of the road. And by that, I mean the T waves. Their distinct shapes tell us exactly what's going on chemically under the hood. If the T waves are tall and peaked, reaching way up, you're very likely looking at hyperkalemia, just way too much potassium in the patient's system. If they're completely flat, like barely a bump on the road, that points to hypokalemia, or dangerously low potassium. And if those T waves are upside down or inverted, the heart is throwing up a flare about ischemia. And step 8 is our final topographical check. This acts as a massive danger sign on our road trip, the QT interval. If you observe a long QT interval, flashing red lights should immediately go off in your head. A prolonged QT is incredibly dangerous, mostly because it can trigger a lethal, twisting heart rhythm called torsades de pointes. It's a really subtle sign that can easily be missed if you aren't strictly following the roadmap, but checking it prevents a totally preventable catastrophe. Section 4. Diagnosing the disease. Time to put it all together. This is where the magic happens. By combining just a few simple data points from our drive, we bypass all the confusion and arrive instantly at a diagnosis. Let's run through it. If your rate is fast, the rhythm is regular, and the QRS is narrow, boom, you're looking at SVT. What if it's fast, irregular, and missing that P-wave traffic cop? That's atrial fibrillation. What about slow and regular with the P waves sitting securely before the QRS? That's just your standard sinus bradycardia. But if it's slow, regular, and that P wave is not followed by the QRS gate opening, heart block. And finally, if it is fast, regular, but the QRS is wide, that points squarely to ventricular tachycardia. Actually, speaking of VT, we absolutely have to pause and highlight this. This is the golden rule of driving in Heart City. Treat irregular wide complex tachycardia as ventricular tachycardia unless there is strong evidence otherwise. Let me just repeat that because it's so critical. When you see wide and fast, you assume VT until proven otherwise. It's a non-negotiable safety principle that every single medical professional needs to have memorized to protect their patients from sudden cardiac arrest. All right, Section 5, the 1-minute checklist, your daily commute. So here is your complete 8-step, 1-minute checklist. Every single time you look at an ECG, I don't care how chaotic it initially looks, you force yourself to ask these exact questions in this exact order. 1. Rate. 2. Rhythm. 3. P waves. 4. PR interval. 5. QRS narrow or wide. 6. ST changes. 7. T waves. 8. QT interval. If you just run through this checklist consistently, you officially replace the stress of rote memorization with a reliable, structured process. You're going to confidently catch the vast majority of common and life-threatening ECG abnormalities in under 60 seconds. We've successfully navigated those squiggly lines by simply following the map. It just proves that structure beats memorization every single time, which leaves us with this final kind of provocative thought. If a simple 8-step road trip can reliably decode the heart's most complex and life-threatening emergencies, what other massive medical mysteries could we solve if we just had the right map? Keep that in mind, stay curious, stick to the process, and I'll catch you in